So I have the honor and indeed the great pleasure of introducing him. You will have seen some of Dr. Raza's credentials in today's program, and while these provide a snapshot of his practice and professional affiliations, they don't come even close to painting a comprehensive picture of his outstanding work and his accomplishments. Citing his background and experience in detail, to set the stage for his presentation would consume most of the time allotted for him to speak. Instead, I'll summarize. He has an impressive academic and practice list of credentials and extensive experience. He is energetic, forward-thinking, socially conscious, and committed to cause. He is genuinely interested in our symposium's focus and has been available, responsive, and a pleasure to work with in preparation for this session. Please welcome Dr. Danyaal Raza.
Thank you, Leslie, for that very kind introduction, and it's a privilege to speak to folks today. It's quite a distinguished lineup, and I'm quite honored to join that. I apologize I can't be there in person. I don't have a good view of the crowd, so I'll lean on Leslie, perhaps you, and then Margaret, it looks like you're in the room as well, just to let me know if there's any questions at all. I know we're going to get into that later, but I'll perhaps lean on the two of you. So my job today is to talk about my healthcare, but in particular, I think to talk about an elephant in the room, and that's how we pay for healthcare and what we could do if we were able to pay a little bit more. Now, I don't have any commercial disclosures relevant to what I'm talking about this afternoon, but I do like to point out that I am faculty, I am a practicing family doctor, but I don't, and I bring an evidence-based perspective to the issues I'm going to be talking about, but my perspective is not values neutral. And so most of that work but not all, has manifested through advocacy work with Canadian Doctors for Medicare. So you'll see that perspective kind of filter out as well. But I wanted to flag that as well. I mean, I think that's the reason I was invited as well, but just wanted to make that explicit. So there's really two things I'm going to do today at the core. The first is I'm going to make the case that we underinvest in the publicly funded healthcare system. And then I'm going to provide examples of what I think are transformative changes if we made the political decision to invest a little bit more. Okay, so let's start with paying for care, with the money question. So many folks will have seen this number or a variation on this number, and this is how much we spend as a country on healthcare as a percentage of our economy. And this is overall healthcare spending, whether we're thinking about a public or private spending, overall healthcare spending. We spend about 11.3% of GDP on healthcare. The comparator countries here are not ones that I selected. They're ones that we often compare ourselves against and that the Canadian Institute for Health Information uses as peers. And you can see we're kind of in the middle. But I just said this is overall healthcare spending. Not every dollar is spent in the same way. And of course, we can look at that dollar in different ways. So I can't see your hands. So I'm just going to throw out a question just to get some engagement early on. And I want to ask folks in the room, you don't have to raise your hand. You can just do this exercise in the back of your head. Of every dollar that's spent on healthcare in Canada, what percentage comes from public sources and what comes from private sources? And private is essentially private insurance or out-of-pocket spending. So is it 10% private, 90% public? Is it 30% private, 70% public? Or is it an even 50-50 split? If folks who are online want to be adventurous and type in your ABC answer in the chat, you're welcome to, but that's certainly not a requirement. Okay, so all right, well, awesome. We do have some brave people online. And yes, and so the answer is 30% private and 70% public. And this has actually been a relatively stable number for a number of years. There's some very minor changes here or there. But here's what that looks like, again, against that same peer comparison. So you can see Canada, we are second from the top behind the United States. And I like to point this out because I think we have this public narrative that somehow public healthcare spending in Canada is out of control or unsustainable, and that we are somehow, pouring money into a system that's not necessarily giving us results. We'll talk about that result piece in a sec. But when you actually look at a share of overall spending, we underspend versus many of our peers, particularly those in Europe. So you can see France, Germany, the Netherlands, the UK, they all spend more than 10% more than we do in terms of share of overall spending on their public healthcare system. So actually, I think I would argue, and the numbers back me up, that we spend less, we invest less in our public healthcare system than many of our peer countries. And if we take that share and we apply it as a percentage of GDP, here's that same graph I showed you for overall healthcare spending, but now we're just looking at public spending. And you can see the difference now is even more dramatic. Whereas when it came to overall healthcare spending, we were in the middle. But when you look at just public healthcare spending, we dropped to near the below of this comparison group. And of course, the corollary is also true that we have a relatively high proportion of private healthcare spending. So, but I've just shown you a snapshot in time, right? Of course, these numbers don't exist, in just 1 year or the other. So I also wanted to show you data from the Canadian Institute of Health Information that looked at the growth rate of both overall healthcare spending and public and private. And so you can see in the first column, I have the year, 2021 to 2025. Then I have the percentage of how healthcare spending has changed, and no surprise, it's risen every year by varying degrees. But interestingly, in 4 of the past 5 years, it is private healthcare spending that has expanded faster than public healthcare spending. So not only if you pick, the year of the data or really any recent year, not only are we spending and investing less from public sources into our healthcare system than other countries, but in fact, private healthcare spending is growing faster in Canada than public spending is. Now, there are lots of different explanations for that, but one of them that I would posit is taxes. So this is a graph from, if people aren't familiar with Our World in Data, it's this really amazing place that brings together data visualizations from all sorts of different areas, including in healthcare. And so here on the x-axis, you can see tax revenues per capita. And then on the y-axis, you can see public expenditure on healthcare per capita. And again, I've highlighted not all, but most of those same comparator countries that were included in my other graphs. And you can see that, I don't think this will surprise many folks, but there's a correlation between how much we invest in public healthcare systems and how much a nation collects in terms of tax revenue. So one of the explanations is if we, for a low public spending, is our relatively low taxes. Sorry, folks. Slides doing funny things. Here we go. And I would argue we're actually, I think, going in the wrong direction if we want to have more fiscal capacity to boost investment. So in the term of the most recent government, we've actually seen a series of tax cuts. We've seen the digital services tax, the planned digital services tax being rolled back. We've seen the rolling back of a modest change in the capital gains inclusion tax. We've seen a recent income tax. We've seen in the last budget taxes to private vehicles like boats and jets, a new corporate tax super deduction, and other ones as well. So, at the same time, we've also seen very large commitments to things like defense moving towards 5% of our GDP. And I'm not here to make a conclusion on whether or not that is a good or a bad idea. I think, we're in a moment of nation building, and there's certainly a strong argument for that. But I do have a high degree of concern that if we are reducing public revenues and making commitments for things like defense for 5% of our GDP, where is the money going to come from for a healthcare system that is already being underinvested in compared to international norms? So obviously, we can have more discussion about this in the Q&A portion, but I hope that I've made the case that our healthcare system needs more support. Our public healthcare system needs more support than it's currently providing. And why that's important is because we are at a crossroads, I think, in the healthcare system. I mean, it feels like we're always at a crossroads. So perhaps this is a bit of um, uh, perhaps this is just a permanent feature of the system, but it really does feel like we are at one. And I say that because across so many different domains of the system, we have a choice. I think a choice towards, and we're having debates about different paths. And I'm not just talking about change versus the status quo, but things that are happening right now that I think risk degrading the quality of care versus opportunities to actually improve care. And so I'm going to present them as these threats and opportunities across different themes. And I'm going to be contrasting things like what's happening with Bill 11 in Alberta and the Canada Health Act interpretation letter with prescription drug coverage, primary care, and surgical care. So I'm going to start with the Canada Health Act, and I'm just going to give some very brief context. So I suspect everyone in the room already knows this, but just so that we're on the same page, the Canada Health Act is a piece of federal legislation, and essentially it is a funding agreement, right? It is a funding agreement between the federal government and provinces and territories, that provinces and territories have to meet these 5 conditions set out in the CHA in order to get and receive the Canada Health Transfer, which is a substantial federal transfer that the provinces and territories depend and rely on in order to fund the healthcare systems that they deliver in their jurisdictions. This was a piece of legislation that was passed in 1984. It's been a very durable piece of legislation. There have been updates and interpretations along the way, one of which I've talked about. But one of the things that hasn't really substantially changed is its comprehensiveness. And this is really what's defined the universality, both the extent and limitations of it, of the healthcare system. And that's that our universal health system is really only universal for two things, physician care and hospital care. For all sorts of other things, whether it's prescription drugs, community-based non-physician care, psychologists, long-term care, we essentially have means-tested or age-tested programs that many, I think, people would describe as, two-tier healthcare. And so that absence of coverage is going to animate many of the choices that I think we have in front of us. But I bring this up specifically now because folks may have been following or reading about this new legislation that has since passed in Alberta that was introduced called Bill 11. And this is quite notable because it is since the CHA has passed, there have been many different attempts to try and unwind the legislation that have mostly happened through the courts. So most recently, people may have been aware of the Canby case in British Columbia. Before that, there's the Shuley case in Quebec. But this is really unique because it's a very explicit and forward-facing legislative attempt by a province, in this case by Premier Danyaal Smith, to introduce a dual practice, private pay for care that is otherwise medically covered and medically insured under the Canada Health Act, which many experts, myself included, interpret as a violation of the CHA. And so I'm happy to talk about this more, but in the Q&A. But I think this is a very serious step we should all be paying attention to. The federal government so far has taken a wait-and-see approach, but many of us are hoping for stronger leadership. Now, that is a threat. The opportunity is that the CHA is the Canada Health Act is a piece of legislation that can also evolve and adapt. It can't really, short of amendments or introducing brand new legislation to cover things outside of physicians and hospitals, we're not going to see the CHA suddenly cover things like prescription drugs. However, one exciting thing that has happened is that in January 2025, the previous Minister of Health, Minister Mark Holland, issued an interpretation letter saying that scopes of practices have changed substantially since the CHA was passed in 1984. And not all, but many things that physicians do now can be done by other healthcare providers. For example, nurse practitioners and pharmacists who can prescribe. And so what this interpretation letter said to the provinces in January 2025 is that we are updating the interpretation of physician services in the CHA to include physician equivalent services by non-physician healthcare providers, and that the provinces have until April 1st, 2026, so 15 days ago, to comply. And the good news is that most, but not all provinces have been prompted to introduce new funding mechanisms, in particular for nurse practitioners, to deliver this sort of care. And this has been really critical because before the issuance of this interpretation letter, across the country, we were seeing, particularly there was well-publicized cases in Calgary and Ottawa, the opening of private pay nurse practitioner clinics, where care was now being determined not based on medical need, but on your ability to pay. So this is an issue that's gotten variable media coverage, but in my view, it's a really important opportunity for provinces to step up and start to more comprehensively fund services that are now under the CHA that were not just over a year ago. I think I have about 10 minutes, 10 or 15 minutes left. Is that right? I just want to do a time check as I move through. Yeah, okay, great. The other kind of crossroads is prescription drug coverage. So people may have heard of the October 2024 Pharmacare Act, which was passed by the last government to expand prescription drug coverage to two types of medications, to contraception and to diabetes. And this is a huge opportunity, but it's an opportunity that's turning into a threat. Because since the federal election, we haven't seen, just prior to the federal election, we had 4 jurisdictions, BC, Manitoba, PEI, and the Yukon, sign on as partners through bilateral agreements with the federal government. And in fact, in BC, drug coverage has already begun to roll out, and we expect it soon in the other jurisdictions. The challenge is since the election, we have seen no more provinces sign on, despite interest in places, particularly in places like Newfoundland and other places in Atlantic Canada. And this is not necessarily a missed opportunity yet, but is one that I think we need to seize, because if you look at prescription drug spending in Canada, it is predominantly out of pocket and through private insurance. So this is data from a few years ago from the Parliamentary Budget Office. And I say that I bring this up because if you even just look in the past few years, these are all reports that have been issued by the by Parliament or by the federal government. This first report, the standing report of the committee, report of the Standing Committee on Health, was issued in 2018. Bill Casey, who's a Liberal MP from the East Coast, was the chair of the committee at the time. It was done in collaboration with New Democrat members, recommended a single-payer universal pharmacare, one that covered not just 2 types of medications, but a comprehensive list. Then the federal government commissioned the Advisory Council for the Implementation of National Pharmacare, whose chair was Eric Hoskins, who's a physician and former Ontario Liberal Minister of Health, who recommended the same thing. And then the October 2024 passage of the Pharmacare Act also formed this National Pharmacare Committee of Experts that issued their report in December. And guess what? Guess what they said? The exact same thing that the other 2 reports have said. And this is a huge opportunity because the multi-tier system we have in Canada for prescription drug coverage is so inefficient that with a relative increase in public spending on prescription drug coverage, we can actually decrease total costs of prescription drug coverage, of prescription drug spending by over $1 billion a year in this country. which is huge. I mean, it will take upfront public investment, but it will substantially reduce costs to employers and businesses. Many small businesses have argued for this as a competitive advantage. And of course, it will substantially reduce out-of-pocket payments for the 1 in 10 Canadians who can't afford to take their medications because of costs. Primary care. Obviously, this is an issue very near and dear to my heart as a family doctor. There's no question, we have a crisis right now in primary care. This is data from the Commonwealth Fund that puts out a report every few years. And you can see that in 2016, the percentage of adults reporting having a doctor or place to go to when they need medical care, we were pretty close to the Commonwealth average. We were 93%, so just a couple points below. But in the years since, and then in 2023, the most recent data, we're not doing so well. We're right at the bottom. And I think so many of us can feel this. I feel this all the time because I'm constantly being asked to take on new patients. And more often than not, I have to say no. And I know many of you, some of you may not have a family doctor, and many of you may know friends or family members who are also without and having to rely on things like the walk-in clinic and the emergency department. But the good news is that if you do have a family doctor, the quality of care in Canada is excellent. So this is, again, from the Commonwealth Fund. It shows all sorts of metrics, whether it's about courtesy and respect, getting enough time, coordination of care. And in all of these metrics, we perform better than the average. Obviously, we can do even better than this, but we perform better than the average. So the question is how are we going to fix this care gap? One thing that we have seen, and this is what I would describe as a threat, is the rise of these so-called virtual walk-in clinics. Some of them are private pay, but some of them have come about through agreements, public funding agreements with provinces. The challenge is they don't conform to what most of us define as high quality primary care, which is the 4 C's we often call it: care that is coordinated, care that is continuous, care that is comprehensive, and care that's coordinated. I think I may have said that last C twice. These virtual walk-in clinics, unfortunately, duplicate a walk-in clinic model that already exists, but without the opportunity to provide in-person care, or even less opportunity to provide continuity. So this was a study that was done a few years ago that found when you compare these virtual walk-in clinics to traditional in-person primary care, they tend to see people who are healthier. They are less likely to have a follow-up visit with the same person, but they are still more likely to have a subsequent follow-up visit, and they're twice as likely to have an emergency department visit within the 30 days following that initial care encounter. So I contrast this with team-based primary care. You know, it's very difficult now to provide care that you, as a family doctor 30, 40 years ago, where it was just you and a nurse. Now the norm that we train trainees and others in is team-based care, where it's not just a doctor and nurse, it's a doctor, nurse, social worker, physiotherapist, other folks who are part of a team that are trained to provide wraparound care. This is not the norm yet, but I think the good news is we're slowly moving in that direction. But the question is the velocity and the speed fast enough? This project is called the Our Care Project. It was done by a colleague of mine at St. Mike's, Dr. Tara Kieran, and I really encourage you to check out the website, ourcare.ca. I highlight it because Dr. Kieran and her team went across the country using deliberative democratic dialogues and processes to ask Canadians, what do you want out of your primary care team? And this standard, these 6 principles emerged. Which I don't think will surprise many folks. That's a relationship with someone who works as part of a team that they can get to know, someone with a team that they can see them in a timely way, primary care that's connected to social care, easy access to your records online, culturally safe care, and care that's accountable to the community that it serves. And the good news is in Ontario, we actually saw the passage of something called the Ontario Primary Care Act, which mandates reporting on Ontario's progress that is actually modeled very closely on reporting on these 6 goals. So this is a huge opportunity if we decide to move forward with it more aggressively, not just in Ontario, but across the country. And the last thing I'm going to talk about is surgical care. Because I think many of us will have experience of this, especially for elective care, waiting for longer than we should um, for the care that we need. The threat here, I think, is outsourced care, and we're seeing this a lot in Ontario. This was a paper that was published not that long ago by a group of ophthalmologists that looked at post-pandemic outsourcing of cataract surgery in Ontario to out-of-hospital for-profit surgical centers. And it actually found that compared to hospitals, those cataract centers were disproportionately seeing folks from the highest income quintile brackets versus the lowest income quintile brackets, whereas in hospital, there was essentially no variation based on income. Not only that, but the expected volume of surgeries done at these outsourced for-profit surgical centers were lower than expected when compared to hospitals. So I would argue if we continue down this path, this is actually a way that could potentially not enhance but diminish capacity for the dollars that we're spending. And it's actually an inequitable way of distributing care, where again, this is all publicly funded, by the way, but still nonetheless, whether it's the sales pressures for being upsold or the actual physical location of these clinics, it is the highest income folks who are disproportionately being served by these publicly funded for-profit cataract surgeries. Now, if instead we made different choices, if instead we invested in similar out-of-hospital premises, but that were operated on a not-for-profit basis, or that were extensions from hospitals. There's a great example in London that was made possible by the donation of Nazem Kadri, who's a professional hockey player who grew up in London and started his career at the London Knights, with the London Knights. He was a Leaf for a short time as well. And if we did things like single entry referral models and advanced practice care with orthopedic surgeons, where you're combining physiotherapists and orthopods at one team, we would see substantial improvements in care. So I'll just read you a couple stats and then I'll conclude and we can move on to questions. So this is a simulation model, the CMAJ paper that was done by David Urbach, who's a general surgeon and a researcher at Women's College Hospital. And he found that if we did and I'm happy to talk more about what single entry referral models refers to, but if we did this combination of team-based care and these single entry referral models, we would see a reduction of waits to surgery ranging from 111 days in Toronto to 281 days, where the waits are the worst in the western part of our province. And then when you look at data of these hospital-based surgical centers that are implementing new high-efficiency care, this one in London is performing surgeries up to 56% cheaper and up to 25% faster than those being performed in traditional hospital environments. And that's reduced waits for non-cancer surgeries elsewhere in the London hospital system by 18%. So I hope I've painted a picture that actually the healthcare system is not about doom and gloom. We have amazing opportunities and innovation that are happening everywhere around us that can make substantial changes to waits and to the quality of care that we're all receiving. But we cannot take blood from a stone, and they need to be supported with new public investments.